Welcome to our newest episode of the Lebanese Physicians podcast. And today we'll be discussing the use of AI in interventional pulmonology with the company NodeAI. And our guest today is Dr. Wael Hanna, who is currently head of the Division of Thoracic Surgery and associate professor of surgery at McMaster University. And welcome, Dr. Hanna, to the podcast.
Thank you, Khalil. I appreciate very much. Appreciate the invitation, and it's a real pleasure to reconnect with you after all these years.
Yeah, it turns out we may have known each other back in the days of AUB, although I'm a bit older than you, I guess. But
Yeah.
well, can you tell us more about your work in thoracic surgery first and at McMaster in Canada, and how you are involved in the interventional pulmonary world?
Yeah. Thank you again for the opportunity to be here. So I've been a thoracic surgeon by practice for about 15 years. And my main research practice areas are in robotic surgery. So I do a lot of three-dimensional guided lung surgery for small nodules during segmental resections for lung cancer. And the second half of my practice is an interventional pulmonology practice. This is very common in Canada, where you have combined thoracic surgery and interventional pulmonology practices. And so for the second half of my practice, I do a lot of interventional pulmonology, biopsying lung nodules and lymph nodes for staging of lung cancer. And that is the second half of my research program.
Excellent. And so basically, I mean, we all know that because I do the same work, I do interventional pulmonology, I don't do the same work that you do, but we all know that when we stage lung cancer, let's say you have a right-sided lung nodule, you need to go in with an endobronchial ultrasound endoscope with the ultrasound at its tip and evaluate all the lymph node stations starting from left to right. And sometimes you have a pathologist with you in the room giving you preliminary diagnosis as you go. And of course, especially when you're doing it with trainees too, it's a very labor intensive and long, could be a labor intensive and long procedure. So I know you've had this experience, and what prompted you, I guess, to think about other options to improve
Yeah,
the process?
it's a great question. You mentioned it's long and labor intensive, but also the result of long and labor intensive is often you biopsy a lymph node and it comes back inconclusive because the patient's not tolerating the procedure or the sample is not adequate. And so a lot of times you have to make clinical decisions based on a hunch. Is the lymph node too small and does it look benign? Can I forego its biopsy because the patient's not tolerating the procedure? Or the result comes back and it's inconclusive. And then you look at the ultrasound images, you're like, this looked benign. I don't have to go back and stage it. And all of that is fine because it's informed by some clinical knowledge, but it's not the best way to treat lung cancer patients, really. If I were a lung cancer patient, I would want my decision to treat me to be based on objective, confident data. So if I am uncertain of a status of a lymph node on EBUS TBNA, there had to be a better way to do this. So we started in our research lab to explore scoring systems. And we came up with something we call the Canada Lymph Node Score, which is a scoring system from 0 to 4. And if the lymph node score is 0 or 1, then it's most likely benign. You don't need to biopsy it, or if you biopsy it, it's inconclusive, you can consider it benign. But if it scores 2, 3, or 4, then it has a high probability of malignancy and should be biopsied. And that was proven by research to be very predictive. The problem with the Canada lymph node score is that it was based on the skill of the ultrasonographer. And ultrasound is very operator dependent. So we couldn't make it generalizable. And at the same time, the iPhone had started recognizing your face. You could Face ID and unlock your phone. So we wondered in the lab whether we could apply the same technology to lymph nodes. Can we take a picture of the lymph node and have an AI algorithm analyze it and tell us if it looks normal or abnormal? And turns out we can.
So yeah, so that's very interesting because right now you're right with the scoring systems, it's just based on you looking at the lymph node, its heterogeneity, whether it's well demarcated or not, and stuff like that. And so it's dependent on the human being or the surgeon. So I would say it's similar to like driving a car, right? You could have a self-driving car, or you could depend on human error and drive the car yourself. So that's probably what
Correct.
you're doing, right?
Correct, exactly. So what we're doing is we're augmenting the decision of the surgeon. So you as an IP physician, you can look at a lymph node and say, yeah, this looks normal to me. It has a score of 1 to me. It's normal on CT, normal on PETs, which we call triple normal. But then the AI algorithm that we developed can confirm your hunch. It can say, yes, this looks normal. So you have one more objective measure. And similar to driving a car, if you're trying to get to somewhere in DC or New York City and you think you should take a left turn, but you're not sure, but then the GPS says turn left in, 200 feet, then you know you're doing the right thing. So it's very, very similar concept.
Right. So basically, how did you develop? I mean, it's pretty intensive, I guess. How did you develop this AI
Yeah.
algorithm? And I'm sure you worked with people who work in AI to get there.
Yeah. It's great. So when we started doing this in the lab, we reached out to the research network at McMaster University, and we wanted to identify a person who has interest in imaging and AI. We were introduced to a researcher, Dr. Anthony Gaddy, who was finishing his PhD at the time. He's now finished, and he's a postdoc at Stanford. And he basically, his research program was looking at MRI of the knee with AI. So we asked him, hey, can you use the same technology to look at ultrasound? It's like, well, let's try it. And we tried it and it worked. And so this is a 7-year long research project with many publications. But what we have now is an algorithm that is trained on about 4,500 labeled lymph nodes, and that can look at a lymph node and tell you with 80% accuracy if this is a normal or abnormal lymph node. It also has very high positive predictive value for abnormal or cancer lymph node, about 97%. And it has so it's a very good test to rule in an abnormal lymph node. So it's a high accuracy, high PPV test, which we feel is something that could be brought to the bedside.
Yeah, so basically what you're saying is when it tells you the lymph node is abnormal, most likely the lymph node is really abnormal and you don't have
Correct.
a need of biopsying it.
Correct. You need to biopsy it, or if you had biopsied and it's inconclusive, you have to consider it abnormal. So you have to go back and biopsy it, or in your decision to treat algorithm, you have to consider it abnormal.
Like, so that's your should you do like to be more aggressive and do mediastinal or surgery to go in and get a bigger portion of the node to see if it's
Maybe, maybe not. I don't think Mediastinal we do anymore. I think
yeah,
EBUS is much better. I think I would repeat EBUS
right.
or EUS before I do a MED. But yes, you're right. You kind of need to do something about it. You can't just ignore it.
Okay. And what if the lymph node is what did the algorithm tells you the lymph node is normal and you
Yeah,
biopsy it and it's so how many normal lymph nodes like let's say that you don't biopsy turn out to be cancer because you could know that data after you do the surgery.
correct. Very little. We did a crossover trial where we tested the algorithm, and we decided that, okay, if the algorithm says this is a triple normal lymph node, so CT normal, PET normal, and then NodeAI normal, it's a triple normal lymph node. We say we're going to skip the biopsy. So we labeled this lymph node as no biopsy. And then we crossed over the patient and biopsied all these lymph nodes as a ground truth gold standard safety mechanism. We missed 1.73% of cancers, which is better than actual pathology because the false negative of pathology is between 5 and 20%, depending on the center. So you miss a little, but not out of the realm of what we have now.
Basically, yeah, I mean, I think it's a so have you seen like any time savings in the procedure when you do this?
Uh, well, the procedure adds a little bit of time. It adds about 24 seconds to the EBUS TBNA
Okay.
because you kind of have to. But where we can see time savings is if this goes to the bedside and it's proven in clinical trials that you can skip all the normal lymph nodes, then instead of doing your systematic sampling, you can do targeted sampling. And targeted sampling saves about 5 to 6 minutes per procedure, which can add up. If you have a full day in the endo suite, you're doing 8 procedures. Now that becomes 9 or 10. And so your wait list shorten. Uh, it's important to know that we're not advocating people not to biopsy. We're just guiding how the decision is made during and before the procedure. So the purpose of the device is not to save time or costs. It's to make better decisions.
Right, exactly. And the other thing that comes to mind as I'm talking to you right now is also with lung cancer, you a lot of times don't only need to get a diagnosis, you also need to get more tissue for
Mhm,
patient analysis and
mhm,
NGS, all this
mhm.
stuff. And maybe I'm thinking that if you're more targeted, then you have more time to get more tissue from the node that you think
Correct.
is going to be positive, so you don't have to repeat the procedure down the road if needed.
That is correct. So, sometimes you're looking at a lymph node station, a 4R usually has multiple lymph nodes. One is anterior to the cava and one is to the right, and one looks bigger, one looks. So, if you want to target one of them, the algorithm can help you decide which is abnormal, which one's abnormal, and which one to target.
Right. So now you told me this is your company is a startup company at this point, and have you started like you probably have not started commercializing that.
Yeah, no, we're clinical trials.
Yeah.
So we have had two in-human trials. We're currently in the multi-center phase of one of our human trials. And so after this multi-center trial, we're able to determine if the device performance is generalizable. Obviously, in our lab, at our center, in my hands, it's doing great. But we have to prove that if we send it to different centers, uh, and we have 7 centers in Canada participating, that it would be generalizable and produce the same reliable accuracy. Then is regulatory. So obviously we have to get regulatory approval from the FDA and Health Canada before we can commercialize.
Yeah, exactly. Because what you're saying is, in your hands, you're skilled. You do this procedure multiple times a day, but in other hands, it might not be the same. And also interpreting, I guess, is it hard to, probably it's not that hard to interpret because AI probably gives you the answer, right?
Correct. So this is a major problem with EBIS and ultrasound in general. It's operator dependent. So you and me and other high volume centers, we tend to have better diagnostic yields because we do the procedure repetitively. Um, But you're right, in lower volume centers or in centers where the prevalence of cancer is lower, the diagnostic yield can be affected. The interpretation is not a problem. The AI will tell you if it's a normal or abnormal lymph node. So that, takes one extra layer of uncertainty. But we need to know whether different devices in different hospitals, you have multiple manufacturers of the device, right? Like you have Olympus and Pentax and Fuji. We have to know that they all produce the same results. We have to know that, different ultrasound processors are configured the same way to produce the same image for the AI to look at. So these are all technical things that would help us test the generalizability.
Yeah, because AI might learn ultrasound images with Olympus, but they might not correlate with what the
Correct.
ultrasound image with Fujifilm or with Pentax are.
Correct. Correct. So if the image is cropped in a certain way, where it's moved to one side or the other, the ultrasound has to account for that. So we would reprogram the algorithm to look at these differences. Yeah.
What about, are you looking at other applications for AI technologies, let's say in peripheral lung nodule biopsies, or what
I get.
listeners like lung lesions that are inside the lung, not outside.
Yeah. So radial probe EBIS, is
Right,
that what you're
right,
thinking?
right.
Um, So it's a very promising field. We haven't done any work on it because obviously convex probe images are different than radial probe
Right,
images.
right.
There is a paper out of Japan that came out recently looking at AI prediction models for lung nodules and to determine if it's malignant or benign on radial probe EBIS. But I'll ask you that. You have you're in a radial probe EBIS, you're there, you can see the lung nodule and it says it's benign. Are you not going to biopsy it? Because I'm assuming you're there to get a tissue diagnosis.
Yeah.
So, although it's possible, it might not have a commercial or clinical need at this point because the reason we get to lung nodules is because we want to biopsy them to get a tissue diagnosis to determine do we radiate them, do we resect them, etc. Whereas lymph nodes, we're staging. And so some lymph nodes need to be biopsied, some lymph nodes don't. And I think that's where the clinical need for convex probe AI guided algorithms is. But yes, to answer your question, it's a promising field. We haven't done any work on it.
Yeah, because I'll tell you what, the way I'm thinking about it is because sometimes you get to a lung nodule, right? You think maybe it's benign, but you biopsy it, and then you go discuss it at tumor boards, and it comes back negative. And then the discussion is it a true negative or is it a false negative? And I'm thinking if you have an algorithm like this that
Yeah,
tells you it's likely benign, the biopsy comes back benign, then you're
yeah,
more sure that this is benign and you're more comfortable following it up over time rather
yeah. You're
than
absolutely right. This is one of the, so post hoc is one of the biggest uses of these algorithms because a lot of these biopsies are non-conclusive or
right,
benign.
right.
The nice thing about lung nodules is they're very sensitive to PET. So if you have a PET avid lung nodule, even if your biopsy says benign, you're probably going to recommend removing it or treating it.
Right.
Um, and if it's a non-avid nodule and it's benign, then you can observe it. And so the utility algorithm would be useful there in that area. Um, and so hopefully somebody picks it up and does it. We don't have any plans for it in our company at this point.
How many years do you think it's going to take to become commercialized?
We are hoping 2027 or early 2028. We're really full on the regulatory pathway right now. We're putting a lot of resources from the company to get regulatory clearance. So hopefully within 2 years, 2.5 years, we can make it available to clinicians like yourself.
Excellent. Well, this was a great discussion. And I mean, it's a great idea and a great company, I think. And it's going to be an innovative thing. I mean, we're seeing AI now penetrate into a lot of areas of medicine. And I think this is an example because people are always scared. They say, AI like is going to take over our jobs or whatever. But this is an example of where it's actually making you more efficient and helping you be more accurate in terms of getting your diagnosis and helping out your patients.
Yeah, you're right. I get asked that all the time, the cytotechs or trainees, like, is this going to replace me? And I always tell them what you said exactly. It's not intended to replace anyone. It's intended to make the entire ensemble of what we do better. And then I say, how did you come to work today? And they'll say, I took my car. Did you use your GPS? Yes. So that's technology, helps you, makes you better. And we use AI every day in our, lives, either on, social media algorithms or, people who fly planes or drive autonomous cars. It's making our lives better. It's making our lives different, but I don't think it's replacing anyone, especially not clinicians.
Yeah, I agree. Thank you, Al, for being on the podcast.
Thank you, Khalil, for inviting me. I'm going to take you up on the offer. I'm going to send you a device to test, and you can tell me what you think.
100%. I'll be looking forward to that.
All right, my man. Have a great day.
Bye.